This podcast introduces Chapter 9 on Airway Management. So, the objectives in this chapter begin, as always, with a review of the essential anatomy of the respiratory system. And then we'll talk about how to maintain a patient's airway, beginning with simple techniques that might happen when you first arrive on scene, how we can keep that airway open with suctioning, gravity, and positioning. And then we'll move into more advanced management of the airway using airway devices, and finally, oxygen administration. Here's the way I think of it. It's a timeline. When you arrive on scene, an airway that is not patent is a life threat. So we have to make sure that that is open. And once it's opened, maybe using a head tilt chin lift method, then we can maintain it. That might be there's an obstruction that requires suctioning, or we can insert an adjunct. And then finally, we support the patient's respirations by administering oxygen, or in extreme cases, we might have to perform rescue breathing. There are a lot of terms in this chapter to be familiar with. Many of them are pretty straightforward, but a couple to pay attention to: gastric distension and just the word patent, meaning the airway is open. So in our overview, having an open airway and maintaining breathing is a life threat we need to be aware of, because every cell in the body depends on perfusion of oxygen to those tissues in order to stay alive. Without oxygen arriving at those cells, cell death can occur pretty rapidly. So we need to be able to assess a patient's airway and correct the problems immediately. Be prepared to open the airway, maintain the airway with adjuncts, and then support perfusion to the tissues, support the patient's breathing by providing oxygen. Let's begin with the anatomy. The airway is that passage that just allows air to enter the lungs. We're going to consider principally the upper airway in terms of airway management. So we have the mouth and the nose, and then the cavities behind those, the nasopharynx, cavity behind the nose, the oropharynx, the cavity behind the oral opening, the mouth, down to the epiglottis, which protects the trachea when we're eating and allows food to go down the esophagus. And then we're going to stop the upper airway basically at the larynx or the vocal cords. Let's look a little bit more detail. The nasopharynx is that opening behind the nose that allows us to filter particles, moisten the air as it enters. The oropharynx also serves that capacity, but it doesn't have, say, the filtering capacity. If either one of those is blocked, air can still get to the lower airway. But it's when both are blocked that we're going to have a problem. The epiglottis, as I said before, just allows air to enter into the trachea, but when you're swallowing, eating food, it's going to close off the trachea and direct foods or liquids down the esophagus, kind of that pathway to the digestive system. Remember, the upper airway stops at the larynx, which is the voice box. Now, the lower airway still becomes important to us. We consider that part of the respiratory system. The lower part of the trachea dividing into bronchi, the branches that go to each of the lungs. Bronchioles are just going to be essentially smaller pipes, and finishing with alveoli. Standard biology answer number 1, surface area. The high surface area of the alveoli allow for the exchange of gases to occur. So when respiration occurs, essentially oxygen is going to enter the lungs at a much higher concentration and exchange with carbon dioxide that may be on the hemoglobin in the blood, which is at a lower pressure in that case. Now, breathing is the mechanical process that just allows for that gas exchange, and we rely on some pretty important muscles to allow that to occur. So inhalation is active. Principally, the diaphragm, which separates the thoracic and abdominal cavities, is a muscle at the base of the lungs, and when it contracts, it shortens. And what that does is expand the chest cavity Air outside at a higher pressure enters the lungs, which is now at a lower pressure, and consequently, the gas exchange occurs in the alveoli. Exhalation is more passive. The respiratory muscles relax, and we get the reverse flow of gases. Now, in addition to the diaphragm, we rely on accessory muscles too, the muscles that you find between the ribs in the rib cage. In summary, we need to be able to assess a patient's airway and support that respiration by opening the airway, keeping it clear, and supporting with oxygen therapy.